Good afternoon, everybody. The academic program starts with, I'll go for Dr. A. Srinivas Kumar. I invite a young dynamic cardiologist and fast-growing interventional cardiologist in our zone, and he's recently conducted the NIC program excellently with great success. I request him to talk on the clinical case selection for CTO PCI clinical assessment.
Good afternoon, everybody. Respected Surprakash sir, the course director and chairman, thanks for kind words, sir. And it's indeed an honor and pleasure again to be opening batsman for this year's ijcto session. As you know, I've been alumni of this SGPGI, and it's a pleasure always to come back to this and participate. We have quite good remembrances of the institute, and whatever we are today, a lot of credit should be given to this institute and its institute's teachers, Dr. Sinha, Dr. Goyal, Dr. Kapoor, Tiwari and others. What Dr. Goyal has asked me to speak is basically on case selection for CTO PCI. How do you assess patients clinically? We would have loved to show more and more angiogram tips and tricks, but boss said you show this, then we will try to do this. That's what I mentioned. This is alumni, SGPGI, and I've been recently fortunate enough to conduct an NIC session here. I think many of you have come here. This is our Honorable Vice President Venkaiah Naidu who came, and we have been receiving a memento from that. And NIC went well with all the cooperation of Goel and all that. Recently joined Apollo group of hospitals trying to coordinate various Apollos to network, and we are happy to share that Apollo with Unity is the strength model, combining all the Apollo groups. We recently in the NIC showed that Apollo group has 19,681 PCI procedures to credit. That's a strength if you all work together, and it is the leading interventional cardiology group. Also thank my FACS professional services colleagues. As a group, we cover multiple hospitals, and that's how we work-life balance and various giving the best to the patients is made possible. If I'm here, other patients are taken care of, my colleagues there. That's how the networking happens. And this concept was appreciated well by none other than European Heart Journal. Why I'm specifically mentioning this, I feel this is the way to go to practice in our country rather than individual approaches and with each interventional cardiologist feeling they are super bosses. If you work together, we can always do good to patients. Is cardiology in India ready to shift from solo to group practice? This is what is titled on. And many other groups are working in our country in the same way. I see Dr. Parik and others sitting here. And it's a welcome change in the country, and more should follow. That's the idea why I projected it. Coming back to CTO, as we are meeting here, in the NIC data we collected showed that CTO's numbers are somewhere around 3.8 to 3.5%. In the last, it is purely reported by individual people. It's more than 16,000 procedures, PCIs in the country, and about 0.3% or even retrograde PCI procedures. And more interest is coming with imaging. About 4% of the procedures are being done under image guidance. Coming back to the topic which Dr. Goel asked me to speak is basically on clinical assessment of patient before we take patient for CTO PCI. It's very important we have to treat the patient as a whole and treat patient, not the angiogram or the CTO lesion per se. So that's how a lot of us were trained, evolved with evolution of interventional cardiology. We have these concepts, but sometimes in young people who are enthusiastically doing procedures, we forget that we need to take care of patient, not the individual lesion. That's how the clinical assessment of patient is very important. And some of the subheadings which you know, like in any field of cardiology, age, sex, and now of late, the frailty concept that is not there in many of these scores are becoming more and more important, especially for interventional cardiology. And clinical presentation, what is the presentation of this patient, and what is the LV function, heart failure status of this patient, associated comorbidities. These have become very important because you might have done the procedure well, but if you have used about 300 ml of contrast and patient goes to end-stage renal failure, dialysis, and then lands in trouble, that's again of no use. So we have to keep patient as a whole and then try to do our best and know when to stop, and try to give 1 or 2 case examples if time permits. I'll go on to the details in the subsequent slides. Age, as in India, as the population is aging, we need to change our concept of age. Previously, patients, when India got independence, we used average age of survival was 47 years. Now it has increased to 69 years. And then previously, anybody who was more than 60, they used to say it is written off. But now that is a most-prime part of our careers, especially probably in corporate setups and things like that. So beyond that is only little elderly type of individuals. Even the WHO has changed the definition of the aging process. It's no more that more than 60 is old. And we even keep going to octogenarians and nanogenarians to do these procedures, which are very elderly. And at least for the day-to-day practical purpose, if somebody crossing 70 and 75 years, probably we need to take more care for these patients as elderly. And if you see the US data, 83% of men and 87% of women aged 80 or more have cardiovascular disease. That means if a patient is more aged, that means more likely to have disease. And 66% of CVD deaths occur in people more elderly. So we need to tune our procedures to take care of these elderly patients. British analysis showed that as the age increases, the complexity of the disease increase. But it's also a welcome change, because if you have seen how we are getting our referral pattern, the patient is elderly, many of the surgeons are also not willing to touch. Many of them come from surgeons too for PCI procedures. Now with data coming up with left main and multivessel PCI stents doing so well, that we can offer this therapy even to these elderly patients. But what we need to consider is assess these 3 important risk domains in this patient. The frailty, this is a newer concept where it is actually recognizable state of increased vulnerability resulting from aging associated decline in reserve and function. Like how young body can cope up with some stress, there is decreased responses in this frail patients. We used to call them poor protoplasm patients. If you do puncture, then it won't contract there, and there are more chances of bleeding and things like that. Other important aspect is comorbidities. Again, if a patient has associated CKD, mild increase in creatinine, now we are more wiser that it is more important to take care and adequately hydrate and other things I have tried to cover up. And disability, again, is not able to carry on routine activities. These 3 form an important concept in assessment of risk. I think any of the risk scores which you see, you have Euro score, you have STS score. These scores never incorporated this newer concept of frailty in the clinical evaluation. And that's how, in spite of the various risk scores being present, still we sometimes fail to assess the patients properly. Johns Hopkins frailty criteria is said that recent weight loss, exhaustion, muscle weakness, slowness while walking, low levels of activity. If 3 out of 5 are there, they're considered frail individuals. If nothing is there, probably they're better. The sarcopenia, that is loss of muscle mass, osteoporosis and muscle weakness, if they are there, you need to be more careful. That is, can somebody correct this? No, okay. Then that is about age, and some of the key points, just to summarize about age, as patients keep increasing, that probably we need to know how to tackle them, because that's the commonest cause of death. Now we have enough data that even 2nd and 3rd generation stents are equally safe. Initially we used to think that BMS is used, but again they have no role. And the complications like antithrombotic therapy being less efficacious and more bleedings are to be noted, and creatinine clearance is what is need to be given. Probably bleeding site time can be decreased by going more and more radial access, though you find more of tortuosities and things like that in this. But in this group also it is found to be beneficial. And to prevent the contrast problems, we need to judiciously use contrast, probably use more patient-specific and less of contrast load. Coming to the other important aspects apart from age, sex, which females have slightly more problems, is a clinical presentation in which the patient is presenting. A patient who has a CTO with a stable angina is slightly different from patient who has MI, now has a new angina pattern. Or sometimes patient need not have any ongoing angina immediately, but you do some sort of stress test evaluation as a nuclear scanner, treadmill, you found ischemia and taking up this patient for angio. There are different subset of patients. And again, for youngsters' sake, I'm telling you, when a post-CABG patient presents to you with total occlusion or a post-stenting, he behaves differently. Once a surgeon touches hand, with due respect to all surgeons, heart gets mucked up, arteries get distorted, and you find a lot of troubles in taking these patients. You need to be extremely careful when you're dealing with post-CABG patients. LV function or heart failure is an important crux of the matter to assess these patients. That is, if a patient is heart failure, again we need to note that heart failure is a clinical assessment, clinical diagnosis, whatever the echoes or others may be showing, though there are pointers to say that severe LV dysfunction, you need to be more careful. Then if a patient has a history of MI with LV dysfunction, severe LV dysfunction, documented viability is mandatory, and if we have more viable area, then only attempt these patients to these procedures. Whereas vis-a-vis a young lady, I will try to show some example if time permits, is young lady coming with global hypokinesia, you can't write them off saying that nothing much can be done because of LV dysfunction. That is a lot of hibernating myocardium. We have seen patients where LVs become totally normal if revascularization is done properly. So we need to guide our therapy, tailor our therapy depending upon the LV function, and fluid overload status, electrolyte dysfunction, hyponatremia, hyperkalemia, if at all need to be corrected before you take these patients on table. This is one of the examples. I thought he has old anterior MI. Some colleagues outside tried repeatedly regarding the anterior wall. They see that LAD is all dead, looks like, and assessment was also done. Then another area, LCX was also tightly stenosed, and we left that LAD and revascularized LCX. Then patient's LV function improved significantly. This is a post-PCI procedure. For sake of time, I'm just running through. And this is another lady, recently, 52-year-old female, who presented to us. And he is diabetic and then had LV dysfunction. Somebody did an angiogram and advised medical management. But I'll just take half a minute. Then the perfusion scan showed a viable myocardium. So this is the angiogram which is showing, again, which shows that, for sake of time, just running. But basically, you have good type of collaterals, then probably that sort of patients will benefit by doing revascularization. If this is the right coronary artery, if it revascularized properly, then probably these patients' LV function improve. Another type of patient, sometimes with history of old MI, also come with collaterals being there now. This is a 78-year-old doctor who came, physician, post-CABG. Initially, RCA was not grafted. Now he had a very tight lesion in the RCA. Then whatever little collaterals were there, we need to handle such patients carefully. Initially tried with softer wires, additional body wire. Then with the help of a balloon, we could cross these patients. And more and more case examples we could see from other colleagues coming. But what I wanted to mention too is you need to assess these patients and also assess which is the culprit vessel presently creating trouble and tackle it rather than this is a distal stent, this is a proximal stent. I think the post-dilatation is done. That is the final result which patient dramatically improved post-procedure. If you had other important comorbidities, anemia, bleeding, and antiplatelet therapy, any such things also need to be taken care along with any carotid or peripheral arterial disease which gives more risk to these patients. And with this, I think I'm end of time. I would like to mention to you that TCT India is about to happen in Hyderabad, July 25th, 26th, 27th. We have all the international Galaxia faculty. We need not go travel all the way to US. We're trying to get it to India and block your dates and be part of it. Thank you very much for patient hearing.
Thank you, Dr. Srinivas Kumar, for the excellent elaborative discussion of the case selection.